Hello friends, greetings from Global Academy of Medical Education. I'm Dr. Vaibhav Seth. I'm your faculty of medicine at GAME. So guys, INICET May 2023. It was really a difficult paper. It was really a difficult paper to say. And why difficult papers? Because a lot of new topics were being asked and there were less number of PYQs. The paper was overall lengthy because you had to try to dissect out the options and all. And last but not the least, the exam was not at all, not less than controversial paper, right? So it has triggered a lot of controversies, which we will talk about. So I'll be discussing the recall of medicines which I have collected from you students. So if there are any discrepancies in the actual question that you have encountered or in the options, please comment in the comment box. So this is a disclaimer before I start with the discussion. So what I have actually targeted is since the questions that were asked, so there were a lot of questions which have triggered controversies. So I've tried to include the snaps from the textbooks so as to highlight that this would be the possible reference, but ultimately the reference it lies in the hand of the examiner who sets the paper. But what we need to know is that what are the take-home messages from this year paper. So if you do this recall based, you know these questions, right? And I have added the references, so that will help you prepare for the next upcoming exam. You can know from where the questions have been asked and you can accordingly prepare your topics. Okay, so without wasting further time, let's start with the recall. Okay, so the first question, guys, it was which of the following is not a reversible cause of dementia. So right, so they are here trying to differentiate between the reversible and the irreversible cause of dementia. So this is a common question that's being asked. So if you look into the options, they have asked about B12 deficiency. If they have asked about hypothyroidism, they have asked about normal pressure hydrocephalus. So these two are definitely the reversible causes of dementia. Now the question would arise whether NPH is reversible or not. So yes, guys, it's reversible. If you put the patient on VP shunt, that's the treatment of NPH. If you do that, then you can reverse the dementia that has developed in NPH. So that's why NPH is considered as a treatable dementia. It's considered as a treatable dementia, right? So we are left with a condition that is known as the Lewy body disease, also known as the DLB. So your correct answer in this question would be option D, that is DLB. Okay, right? Next question, it was basically on hemi-neglect. Now this is a repeat question, the question that was asked on hemi-neglect. So what you need to know is that about hemi-neglect. Hemi-neglect basically is a function of non-dominant parietal lobe. It's basically a function of non-dominant parietal lobe. So symptom wise, what you're gonna get is that the patient would have ignore the left side. So symptom wise, you're always gonna get left hemi-neglect. Symptom wise, you're gonna always get left hemi-neglect. So what is the area that is being damaged in a hemi-neglect syndrome? It is the non-dominant parietal lobe, and in most cases it is the right parietal. That is the right parietal. So you should remember that hemi-neglect comes from the non-dominant parietal lobe, which is the right parietal. So here the answer would be right posterior parietal. Okay, so there should not be any controversy with this question. Next question was easy. They have given you a picture of image based question on plantar response, that is the Babinski sign that was asked. So it's one of the repeat questions, so that was not very much difficult. Okay, next, one of the question was asked on treatment of choice for TTP. So as you guys know, TTP arises due to the deficiency in the enzyme ADAMTS13, which cleaves the von Willebrand factor. So when the enzyme is deficient or reduced in number, you're gonna have high molecular weight von Willebrand factor in the circulation that's gonna break down the platelets. The treatment in this case is plasmapheresis. The treatment in this case is plasmapheresis, right? So that was not a very difficult question from DTP. The treatment in this case is plasmapheresis, okay? Now, this was a tricky question, right? So we'll follow this question. Question was, you have a patient with daytime sleepiness, memory loss. So if you are having a daytime sleepiness, you can think in the line of OSA, you can think in the line of narcolepsy. These are some of the causes of increased daytime sleepiness. Okay, but along with that, you have to focus that the BMI is on the higher range. So you are getting increased BMI. Now this can force you to easily mark obstructive sleep apnea as the answer. But what you have to follow here is that patient is having a acidosis. Normal pH is range in the 7.35. The patient is having acidosis and there is elevated PCA2. There is elevated PCO2. So if in the question you have OSA plus hypercapnia with increased BMI, this should be the feature of obesity hypoventilation syndrome. This should be the feature of obesity hypoventilation syndrome, right? Just to make you understand from where the question was taken, I have taken the screenshot from the Harrison. So it clearly says that you have BMI that's on the higher range, and you have hypercapnia. And 90% of these patients have OSA. So the answer here is obesity hypoventilation syndrome, right? So for those who have actually marked OSA, I mean, you need to improve on your concepts. Okay? Now this question was match the following. So where do you guys get crazy paving pattern? So you get in crazy paving pattern, you get in pulmonary alveolar proteinosis. So PAP is associated with, capital C is associated with D. So if I just make it 1, Roman 1, 2, Roman 3 and Roman 4. So what you're gonna have is C is associated with 4. Okay. Now mesothelioma can cause pleural effusion without mediastinal shift because it's a tumor of the pleura. So A would be associated with 2, right? Kaplan syndrome is associated with coal workers. Okay. So D would be associated with 1. Okay. And finally you are left with asbestosis, that would be associated with lower lobes. So B is going to be associated with lower lobe. So this is how you had to solve this question, right? Now, this is another controversial question that was asked. So you have a ABG that is showing sodium 145, that has got bicarb, that's got chloride, that's got potassium, and that's got a pH. So from here, you are sure that the patient is having an acidosis and you are being told to calculate the NIR-gap. Now guys, what I need to tell you, normally we do not include potassium in the calculation of NIR-gap, even if it's mentioned. In European states, they calculate potassium in the NIR-gap, and accordingly their NIR-gap values are being altered. So what we are doing here is, we are not including the potassium in the equation, right? To make you sure that this is what is being followed. So I have taken from the Harrison that they are clearly writing it that the potassium is typically omitted from the calculation. So if it's 145 and it's 90 plus 20, so it's going to come around to 35. Right? So that would be answer, and the take home message from this point would be potassium is omitted from the NIR-gap question, right? So that you have to remember. Now high output cardiac state. High output cardiac states are beriberi, AV fistula and anemia. Now coming to the core per mole, I mean in chronic lung disease, as per the Harrison, even in chronic lung disease you can have a high output cardiac failure. I'll just show it to you, this the table from the Harrison. But these three options are the better options where you can have high output cardiac failure than the core pulmonal. So in this case, the answer would be core pulmonal. The best answer would be core pulmonal. Now, if I show you the table from the Harrison, right? So they are telling you you have anemia, you have AV shunt, and you have beriberi. All these are causes of high output cardiac failure, but they have also included chronic lung disease. They have also included chronic lung disease, right? So next time if you get such a question, and if you get a very close option between a chronic lung disease and something else which is not part of the high output cardiac failure that is given in this table, think about the fact that CLD can also cause a high output cardiac failure, right? Next, we're going to talk about, there was a question on thrombocytopenia. So I'll just tell you that they were asking about the threshold probably, in which, at what is the level of the platelet count where you can transfuse the platelets, right? So if it was asked before surgery, then the answer would be 50,000. So this is the table from the Harrison which I have taken. They have clearly mentioned what should be the threshold for platelet transfusion, when it should be 5,000, when it should be 10,000, when it should be 50, and when it should be 80, right? So that was the question on thrombocytopenia. Now they had asked the complications of massive blood transfusions, right? So in the blood, we have too much of citrate. So that precipitates the calcium and causes hypocalcemia. Apart from that, other things that we have is hyperkalemia, we have metabolic acidosis, we have dilutional coagulopathy, and we have hypothermia. So these are all the complications of massive transfusion. Next, they had asked you the following areas of CVS examination are to be considered, and they're asking you to, during the examination, what should be the sequence to examine if done on the left side. So that's a very important thing. You are doing on the left side, and they have asked you to arrange it from the superior to inferior, right? So if in the option, if apart from aortic, if the tricuspid was given, whatever be the case, the sequence would be pulmonary would come first, right? Then would come the tricuspid, and then would come the mitral. Okay, aortic area rise on the right side, so that should not be the part of the option. So whatever you do, the option of mitral would be at last. It would be at last. Okay. Next, the question is, a patient has been vomiting from last 2 days. So when you basically vomit, you take out the acid. So if you take out the acid, what you're going to have is metabolic alkalosis. With alkalosis, you're going to have depleted potassium, right? And since you're taking out the acid, you're going to decrease the chloride levels. So hypokalemia, hypochloremia, metabolic alkalosis, all these three options are correct in this scenario, right? Now you're being asked, a lady is taking a oral diabetic drug which reduce the hemoglobin A1C levels, and there is increase in the GLP-1 levels. Now mark it, the question is saying oral. So you have DPP-4 inhibitors. That increase the GLP-1 level. So what are the DPP-4 inhibitors that we know of? We know of the gliptins. So in the option, do we have gliptins? Yes, sitagliptin. In the option, we have sitagliptin. Again, from the other angle, if you look, that these are the two drugs that are mostly given in the parenteral route, and these two are the drugs only that we give by oral route. And metformin definitely does not cause high GLP-1 level. So that's by the exclusion also you can reach to the following fact that sitagliptin is the best answer here. Next question was, a patient came with watery diarrhea. So diarrhea is there and vomiting is there, and the patient has become hypotensive and unresponsive. So with the clinical findings, what is the diagnosis? So definitely if you're having a diarrhea and vomiting, your high chances there you could develop a hyponatremia. Right? Now with hyponatremia and the patient is unresponsive, so definitely there could be severe dehydration. Now I'm not very sure about the wordings of this question, right? And they have also given CVT and HUS as the option. If these two are also given in the option, so let me tell you, if there is severe dehydration, that's one of the risk factors for developing CVT. So according to me, I'll take three options here. I'll take A, I'll take B, and I'll take D as the answer to this question. So guys, I want you to, guys, if you're watching this video, I want you to comment on the comment section and tell me that what actually were the wordings of this question, what were the actual options. So accordingly, I'll be able to tell you the best possible answer. But if this was the wording and this were the options, then according to me, these three will be the definite answer, right? I have included CVT as a fact because dehydration is a very important cause of venous thrombosis, right? Okay. We'll move to the next question. Now, this question was being asked about subclinical myocarditis. Subclinical myocarditis. So, if you look into the Harrison, what is they have given about subclinical myocarditis? That the patient would have no cardiac symptoms. There will be no cardiac symptoms. But what will be there? There will be elevated biomarkers. There will be elevated biomarkers. ECG would suggest of acute injury, and you're going to have decreased EF, you're going to have RWMA. These are the things that have been given for a possible subclinical myocarditis. So very important to remember that you won't have a cardiac symptom. So cardiac symptom will not be there, but we'll have elevated biomarkers. We're going to have decreased ejection fraction on the echo. We're going to have RWMA, and the ECG would be suggestive of myocarditis or acute injury. So all these four options are correct. All these four options are correct, right? And I have given you from where the reference has been taken. Now the question is, a patient has been put on anti-diabetic drug. This was a very easy question. HbA1c has been reduced and you have a vulval pruritus. So that means it is one of the side effect of SGLT2 inhibitors. What is the SGLT2 inhibitor that we are thinking of here? Canagliflozin. So that would be the best answer, because this is not a SGLT2 inhibitor. This is a glimepiride. This is a DPP4 inhibitors. So right. So we are thinking of canagliflozin in the answer. There should not be any controversy to it. Next question was iron profile in iron deficiency anemia. So what we have in iron deficiency anemia? We have decreased iron. We have decreased ferritin, right? We have decreased transferrin saturation, and we have increased TIBC. We have increased TIBC. If you guys know that transferrin saturation is basically equal to serum iron by TIBC into 100%. So in iron deficiency anemia, this is increasing and this is decreasing, right? So transferrin saturation overall kind of decreases. Overall it decreases. Okay. So we have decreased ferritin, we have decreased serum iron, we have decreased trans saturation, and we have increased TIBC. So all the four options are correct here. All the four options are correct in this question. Okay. Next, the question was asked on hepatitis graph, and probably they had asked you to label this antibody, right? So you know that first thing to rise in the blood is HbS-Ag. Then you have a window period. In this window period, you only get the HbC. So some antibody that is persisting from the starting is anti-HbC. Now this can be IgM before the window period, and after that it can become IgG. So this was an easy question, right? Now next question they had asked, cholestasis is mediated through which of the following proteins? Now I can tell you this was also one of a controversial question. I'll tell you why this was a controversial question. The proteins that they have given, all of these are useful in the, all of these are implicated in the diagnosis of hereditary hyperbilirubinemia. So if you know the metabolism of bilirubin, so what is happening here is bilirubin comes here bound to albumin. It goes inside as bilirubin, then it gets conjugated. It gets conjugated by the enzyme UDP glucuronide transferase. Now then it has to be secreted outside. It has to be secreted outside by a protein known as MRP2. By a protein known as MRP2. Now that's the rate limiting step of bilirubin metabolism. Some amount goes outside by MRP3, and that is being taken reuptake by OATP1B1, right? Now these are the proteins that are implicated. So if I just go by this sequence that the rate limiting step is affected, so that can cause cholestasis. That can cause cholestasis. So given the genes that are given here, genes of the protein that are given here, the best answer would be MRP2. best answer would be MRP2. But if you look into the table from the Harrison, they have clearly said that MRP2B or O8TP1B1, they do not have cholestasis. So the better question would have been giving something from here. If these proteins would have been given to you, that would have been a better answer. So I would like you guys to comment whether MDR3 was given in the option or not, right? Whether MDR3 was given in the option or not instead of MRP3. Because if these are in the options, then the single best answer would become MRP2, but I still will not be comfortable in marking this as a option, right? Okay. So the next question was the amyloid protein that is deposited in dialysis patient. This was very easy. So you have the beta-2 microglobulin. So do we have more questions? No. Right now we don't have more questions. So guys, please comment in the comment box below if you feel that there has been any discrepancy in any question. If you feel that there are certain areas where you want to discuss with me, you can put that in the comment box. You can mail me in this. You can mail me here, right? You can mail me here if you have any doubts, and if you feel that there were any other questions that you can come across, you can send me or drop me a mail here, right? So I hope you guys should not be stressed out for anything. If you have not performed well, don't worry, you can do well next time. Thank you.